and go with Dr. Moss.
Great, thanks, Barry. If you can stop share, I can share my slides.
Yes, there we go.
Yeah. All right, thanks a lot everyone for being here. I'm Jennifer Moss. I'm going to talk today about a project I have been working on for the last several months, examining overscreening among older adults, overscreening for cancer. And in this case, I'm really talking about screening after the recommended upper age limit. So based on the data that we have about risks and benefits of cancer screening, organizations develop guidelines about who should be screened and who should not. But we see that people continue to get screened after that recommended upper age limit. So, it's the same data, but different guidelines from different organizations, and then different healthcare practices actually occurring between patients and providers. So the data that influences these policies and these healthcare practices really points towards upper age limits when cancer screening is no longer appropriate. And the reasons for this, cancer screening guidelines always weigh the risks and benefits of screening. But we see that for older adults compared to younger adults, the risks and benefits are different. So when we think about the risks of cancer screening among older adults, these tend to go up compared to younger adults. So older adults are more likely to experience side effects and harms of screening tests, as well as the follow-up and treatment procedures that can occur. And these side effects can be really quite serious. You can think about perforation of the colon, side effects from anesthesia, even death that can come from colonoscopy, which those are the clearest examples of harms that can accrue, risks that can accrue from cancer screening, and they are more common in older adults. On the other hand, the benefits of screening go down for older adults versus younger adults. For older adults, they tend to have more comorbidities and then shorter life expectancies. And as we know, it can take years or even decades for the benefits of cancer screening to accrue to patients. And these older adults may not be able to experience those benefits. And older adults tend to be diagnosed with slower growing, smaller tumors that really are not going to, often would never cause any clinical harms. So diagnosing and treating those tumors doesn't bring a lot of benefit and value and quality to these patients' lives. So the risks are greater, the benefits are smaller for older adults compared to younger adults, but it's important to remember that this balance can change over time. As cohorts age in and out of the recommended age range for screening, each cohort carries with it a unique set of risks and comorbidities, and treatments and screening tests also evolve over time. So while we have data right now that tells us what the guidelines that support certain guidelines, it's important to keep monitoring the risks and benefits of cancer screening among all people, but especially among older adults. That said, we have data now that show these risks and benefits, but we know that people continue to get screened after the recommended upper age limit, and this can occur for lots of reasons. From the patient perspective, patients can demand a lot of screening. They've come to expect screening from years or decades of engaging in cancer screening. There are lots of very effective public health messages about the importance of getting screened. So patients have a high level of demand for screening, very favorable attitudes and intentions towards screening. From a provider's perspective, providers are very motivated to diagnose any cancer that could be evident in a patient, both because they want to avoid cancer in their patients, but also from a malpractice perspective, they don't want to get into any trouble for not catching and diagnosing a cancer when it could have been detected earlier. And then from a systems perspective, we know that hospitals, clinics, providers are motivated to continue screening because insurance companies continue to reimburse these tests. So insurance companies, even when patients are age out of the recommended age range for these screening tests, insurance companies tend to reimburse providers for administering these tests. So from a systems perspective, it makes sense to continue administering these exams. So with all that background, you know, I want to share the guidelines for cancer screening put forth by the U.S. Preventive Services Task Force. As I said, a lot of different organizations put forth lots of different recommendations, but these ones are really important in the U.S. because they're often tied to insurance reimbursement practices. So the USPSTF is an independent body that grades the strength of the evidence and the quality of the evidence in terms of the risks and benefits of a certain procedure for a certain population. So I've listed the key here on the right, and on the left is the guidelines for each cancer in each age group. So for colorectal cancer, visualization and stool tests are recommended for people ages 50 to 75. That's a grade A recommendation. But for older people, highlighted in red here, routine screening is not routinely recommended. For cervical cancer, PAP or HPV test up through age 65, then there's a recommendation to no longer screen for women ages 66. Hi, if you're on, can you mute yourself, please? And then for breast cancer, recommendations up through age 75. But we have anecdotal reports and some small studies in the US that indicate that overscreening actually is pretty common. So for this study, our aims were to estimate the national prevalence of overscreening for cancer among older adults in the US, and then identify groups who are at risk of overscreening, a pretty straightforward analysis. It always seems straightforward at the beginning, right? So to do this, I used data from the Behavioral Risk Factor Surveillance System from 2018. This is an annual survey conducted by the Centers for Disease Control and Prevention. It's a nationally representative survey of community dwelling adults of all ages. So I looked at certain age and sex groups to assess whether or not they reported having a screening test after the recommended upper age limit. So the definitions are listed here on the table. The analyses were stratified by sex. So we looked at women separately from men for colorectal, and then cervical and breast was just among the females. And then I listed the covariates here as well. And then once I pulled together all the data, just estimating the prevalence of overscreening and then running some regression models to slice the data in different ways to understand who's at risk for overscreening. So let's look at the results now. So this is the descriptive statistics for our sample. So across the top, you can see the sex and age groups and the N for each outcome, each subgroup. Each group had at least 20,000 participants in the survey. And then across outcomes, you can see that the groups are pretty similar. Most of these participants lived in metropolitan areas, had a usual source of care, good self-rated health, and their demographics were pretty similar to each other as well. And I will say that these proportions are weighted to the US population, so they are nationally representative. Okay, so then looking at the actual prevalence of overscreening. Among men, what I found was that 59% of men reported being screened for colorectal cancer after age 75. And this was more common among men who were Hispanic versus non-Hispanic. The adjusted odds ratio there is 1.9. For colorectal cancer screening among women, it was pretty similar. About 56% reported being screened after age 75. And this was more common for women living in metropolitan or urban areas than non-metropolitan or rural areas. For cervical cancer, the prevalence was about 45% being overscreened after age 65. And we see a number of covariates here that I've listed on the right. Metropolitan status, having a usual source of care, and having higher self-rated health. Finally, for breast cancer overscreening, the prevalence was actually 74% of women reporting being screened after age 74. Again, a number of covariates, including metropolitan status, the demographics, and having a usual source of care. So comparing across these different outcomes, I've listed here the prevalence of overscreening for each cancer, as well as the adjusted odds ratios from the full models. So, for each outcome, at least 45% of older adults report having been screened after the recommended upper age limit. And we see some pretty consistent differences by metropolitan status and some of our demographic variables as well. So before I go into the meaning, the implications of these findings, I want to touch a little bit on the limitations of these data. First of all, it is self-reported data, which is always subject to recall bias, both in terms of actual receipt of each of these exams, as well as the timing. Was it 1 year ago, 2 years ago, 5 years ago? In addition, we didn't have individual data on their risk factors for cancer, if they had had a previous abnormal screen, if they had a family history of cancer, and some of these factors would have made it appropriate for some portion of these participants to continue getting screened for cancer. So taken together, these limitations indicate that probably overscreening was overestimated in this survey. But until we can do a medical record review for each individual patient, it'll be really hard to assess the degree of overestimation here. And in terms of caveats, a lot of people talk about, when I talk about these findings, this project, talk about healthy older adults that they know in their 80s and 90s who are running a couple miles a day. And that's true. And the patient and provider are ultimately the decision makers for screening here. But at a population level, healthy older adults, unhealthy older adults should not routinely be screened in this age group. And in 2020, of course, we must talk about the implications of COVID for these screening rates. And we've seen nationally that screening has dropped. Spoiler for the next presentation, perhaps. And I would hypothesize that dip in screening over the last several months since the pandemic started would be even more pronounced among older adults. Older adults are more at risk for COVID complications. So it's possible that those people above the recommended upper age limits would selectively opt out of cancer screening because they want to minimize their risk and exposure in a healthcare setting. But we'll need to continue to monitor those trends in the future, in the coming years, to see if overscreening reduces in step or even more than we see for screening rates for the appropriate age range. Now, all that said, I want to touch on some of the implications of these findings for clinical care. First of all, we know that the provider, the clinician, is the gateway for screening. A patient needs to have a screening test ordered or has to see a provider to get their screening test. So we need to understand how we can leverage that patient and provider relationship to reduce overscreening. Older adults tend to have longer, higher quality, more trusting relationships with their primary care providers. And that may be exactly what we need to support these conversations about screening cessation, which could be sensitive if issues around life expectancy come up, but we really want to reframe it as more you're graduating from screening, and screening is not going to be a high value for you because of these risks and these benefits. In addition, it's really important through those patient and provider interactions to reduce the unintentional harms of screening older adults. And I've listed some of the potential harms of screening and touched on them at the beginning of the talk, but it's important to remember that several of these, get more common or more serious with age. And so continuing to offer and administer cancer screening to older adults really does put them at risk for side effects and unintentional harms. And it's often hard to see that giving a screening test can actually hurt your patient, but we know that that's true from the data. And in terms of policy, I always make a plug for funding and more research, right? We need better research on ways to reduce overscreening, perhaps through that patient and provider relationship, and continued research to monitor the risk and benefit ratio to better characterize that ratio among older adults now and in the future. And this will require the large longitudinal studies, the screening trials like the ones Dr. Kramer has been involved in, to continue to assess who benefits the most and who gets value out of cancer screening tests. And when we think about the healthcare system, there are some changes that these data point to as well. Number one, as I mentioned earlier, these issues around insurance reimbursement are a way we could change clinical patterns by de-incentivizing the system from administering these tests that are not high quality and could be accruing harms to our patients. And because of my interest in geography and cancer, I was really struck by the difference in metropolitan status for people who are overscreened versus not. And we know that in rural areas, there's less access to healthcare resources. And as we work from a policy perspective to increase access to clinics and providers and healthcare resources in rural areas, we'll need to balance that by making sure the care that we make available in rural communities is high quality and doesn't introduce higher rates, higher levels of overscreening in those rural populations, because we saw that they were less likely to be overscreened. But as we make screening resources more available, we want to keep that level of overscreening down as much as possible. So in conclusion, cancer overscreening among older adults was very high in the US, over 46%, depending on the cancer outcome that we were assessing. And this was particularly true for women in metropolitan areas. The take-home message here is that current patterns of clinical care are not supported by the available data and policies around risks and benefits of cancer screening in older adults. So we need better data disseminated to providers and clinics and systems around the US, and better interventions to reduce the number of unnecessary tests, reduce the potential harms that come from these tests, and to improve public health and quality of life. So with that, I want to thank my co-authors and thank all of you for listening, and I will be happy to take questions now or later in the dialogue. Thank you.
So we're going to reserve questions to the end of the session after Dr. Berry's discussion. So Don?
Thank you.
Don, you may be on mute. Don, you need to unmute yourself.
Okay. Can you hear me now?
Yes.
Okay, thanks. Sorry about that. Thanks to Barry and Stephen for inviting me. I'll talk about modeling. There are model homes. There are model humans, or at least human models. There are model trains and planes, models of cars. And we're going to actually look under the hood of some of the models, at least one of the models. We're not seeking to change the carburetor. We're seeking to look to see if we can find where the rattles are. This is what a model is defined to be. I'm particularly interested in the mathematical model that's a description of some system using mathematics to try to learn something about the system. All mathematical modeling requires assumptions. I'll stress that. If you don't like the results, you should look to see if you can find out which assumptions you disagree with. Model conclusions depend on the inputs, assumptions, data, the character of the model. And if the inputs are bad, garbage in, garbage out, even if the model is great. If the model is built, as I think it should be, to incorporate uncertainty in the assumptions, you start with uncertainty and you end with, hopefully, if the model is any good, less uncertainty, not complete certainty, of course. And so that's my perspective. It's not a perspective in many models, and I'll talk about some where it is not. I want to give you a simple mathematical model, one that's not controversial, except the assumptions are, one can criticize and are obviously wrong. But the assumptions make the results understandable given those assumptions. So one that I don't like, but I made because others do and because it makes things easy. Cancer is uniformly fatal. If you live long enough, you're going to die of cancer. Screening is perfect. This, of course, is wrong, but it sets the stage for, interpreting the effects of screening. Sojourn time, the time between when the cancer is detectable by some screening mechanism and when it would have become evident clinically. The sojourn time, I assume a distribution for that. It has a mean. The distribution is exponential for those of you that know what that means, and for those of you that don't know what that means. Cancer survival, if the sojourn time is long, it suggests that the cancer is slowly growing. If it's slowly growing in the preclinical state, it's probably going to be slowly growing in the clinical state. And so I assume, again, the assumption is wrong, but it might be not unreasonable, that cancer survival after clinically detectable cancer is 3 times the sojourn time. It's going to be longer for longer sojourn time, whether it's 3 times or varies considerably from one tumor to another, is of course an issue. Screening program is every 5 years between the ages of 40 and 80. I'm going to simulate 100 cases, 100 people that were detected or at least had cancer at some point. And I'm interested in the method of detection and whether the cancer was overdiagnosed. The starting ages, considering the gamut from 40 to 74 for these 100 cases, and death from competing risks at age 80. A more reasonable thing would be to model what is the age separate from cancer at which the patient would die, but I want to keep it simple. I'm not addressing treatment or screening efficacy. And so this chart is simple to explain. There are 100 vertical bars. Each vertical bar shows, the bottom of the bar shows the when the cancer becomes detectable by some screening mechanism. The mark that I'll point to with my arrow for this particular person, this horizontal mark is when it becomes clinically evident. And so, and these horizontal bars show the screening times. This is age 40, age 45, etc. So this particular person had a cancer which would have been evident at age 51, the value over here. Had she not been screened, the cancer would have been evident at age 57, it looks like. So this sojourn time for this patient is that. It's about 6 years. And the latter part of the time after detection is what's called the lead time. This particular bar is blackened, and it's blackened because the sojourn time contains one of these horizontal bars. This cancer would be detected at the person's age 55. And the person lives from cancer until age 76. The black bars are, as indicated here, screen detected. That is, the screening test occurred over in the sojourn time. Something that occurs within 2 screening periods, such as this cancer, it looks like a green bar, because here is the time of detectable by screening, here's the time detectable by clinically, and they're within the same period, and so that would be an interval cancer. The person's cancer would be known from here, as opposed to from any screening. And overdiagnosis, the red bars, are all on the top here because of that assumption that all cancers are fatal if you live long enough. It means that this particular person who had a cancer detected will live till age 80 if she's not or he's not killed by the cancer, and the person eventually dies here. This person was not detected until she was age 75, or not detected, but detectable by age 75. And by age 80, where she died, or he died, the cancer still had not become clinically evident. So that's overdiagnosis. There are 20 of these 100 that were overdiagnosed, all of them with these stalactites hanging from the top, to Jennifer's point. The interval cancers are 43 and screen detected 37. So I want to summarize that in terms of the observations. For screen detected, either overdiagnosed or not overdiagnosed, but screen detected, these numbers that I indicated before. The sojourn times vary considerably, with the overdiagnosed much worse. These tend to be very slowly growing cancers. The screen detected otherwise also are kind of slowly growing, not as slowly growing as these. And interval cancers are very rapid growing. These are the cancer survival times. Notice that if you are a long-term survivor you're more likely to have an overdiagnosed cancer. I'm inferring something about that in the opposite direction. What this is saying specifically is if you do have cancer and you are overdiagnosed, that you will have a long survival time due to cancer. What I haven't shown you is what would have happened without screening, and just to set the context. This, by the way, the sojourn time is, mean sojourn time for non-screening is 3.6. That should be 4 if the data were reflecting perfectly the assumption. I assumed a mean of 4. This is a variation from that because of random variability. A year ago, we had a hurricane in the United States called Dorian, and it was predicted it was currently, at the time of this prediction, it was predicted to go toward Florida, but then turn north. And these are the specific points where the model is predicting. But it's deterministic. There's no variability. In fact, it says it's going to go over on that Sunday, it's going to go over Newfoundland. It never went over Newfoundland, not the center of the storm. It rather stayed in the water. So this is, it's not right. George Box said all models are wrong, but some are useful. My variation of that, models that incorporate uncertainty, that is stochastic models, are more appropriate and more useful than deterministic models. And modeling uncertainty in weather uses either spaghetti plots or cones of uncertainty. Here's a spaghetti plot. You see where it got its name? These are like 25 simulations that use the data about pressure, pressure systems, high pressure systems, low pressure systems, the competition. Here you'll see one of the plots is really curvy. This is because that particular simulation had a set of assumptions about the temperature of the water, which is uncertain, where the high pressure system is going to be, which is uncertain, and it said that the thing was going to move slowly and bounce back and forth. In fact, that was what happened with Dorian. For those of you that follow, this was much in the news. Trump once tweeted, certain models strongly suggested that Alabama and Georgia would be hit, and he was greatly ridiculed for that, which became a major, believe it or not, a major political issue in the United States. So another way to show it was with this cone of uncertainty. This is for the center. Where is the center of the hurricane going to be? And this is a plot of essentially the same plot we just saw. That was the point estimate, but recognizing the uncertainty. And that's really critical. It's become critical in weather. It has to become critical in medicine. Here's the actual path, and you see that it was pretty good, certainly within the cone and represented by the spaghetti plot. What about breast cancer mortality in the United States? This is up to the year 2010. Where is it going? And can we use this spaghetti plot idea to recognize the uncertainty, to sample from the uncertainty, and to develop spaghetti plots? So this is a model that I developed using the simulations, what's going to happen in this case after the year 2000. This assumes no further advances in screening or treatment. Another kind of modeling, Barry and Phil Prorock and Gil Welch, of course, estimated that this is a model. It's a pretty simple model, which they're proud of. This assumes that the incidence will continue at about the same level, and but this is screening. Screening increases the incidence by 30%, and implicitly, this is the overdiagnosis. The same kinds of things have been done by Jorgensen and Gotchi here in UK to address what happens. And what they did, this is you're too old for screening. This is you're too young for screening. This is plotting the expected versus what they actually observed. And in between is where the screening program was introduced in this period. And it went up, obviously, and it stayed up. And so they use this slope to estimate. Similarly for Sweden. Enter Rocky Foyer and his brainchild, the CISNET that Barry mentioned earlier. I have one of the breast models, of which there were 7 when it was introduced in 2001. And we published our results. This shows something about the inputs. We had lots of inputs. This is an example that we published of the schedule of mammography for women in the 40 to 79 range. The benefits of therapy, depending on stage, depending on age, depending on a number of things, including biomarkers. These are the outputs for each of the 7 models. The black curve is the actual up to the year 2000. And this shows what the models did, the 7 models, one of which is model W. And I selected this to show what the assumptions were, to elucidate the assumptions, and it's in the journal. If there's no screening or adjuvant therapy, this is mortality, not incidence. So it's hypothesized to continue. And that's because of something called an age period cohort model that assumed something about what was going to happen. It's a counterfactual without screening or therapy. We also published, this was controversial even amongst ourselves. This is model M, model W, and the other of the 7 models. And what I showed here is kind of the hill representing the modeling variability. And it even goes down to 0 benefit for screening. So this is how much of the benefit is due to screening versus adjuvant treatment. And my estimate was model M here was 20% for treatment and 10% for screening. The New York Times got it right. What seems most important is that each team found at least some benefit. Likelihood they are beneficial seems a lot more solid today than 4 years ago. And now the overdiagnosis, women still need to make their own judgments as to whether the usefulness of the screening outweighs the risks. I actually, looking at that contour plot earlier, I actually, in model M, I do like the hurricane spaghetti plots. And these are the various estimates. If you put those, this is forward a little bit, I did this later. The 7 models from the New England Journal, model M is of course at the middle. That's the way I got the middle, was to take the middle of these many plots. But notice that all of the models were encompassed within model M. Fast forward 2016, actually 2009, we helped the U.S. Preventive Services Task Force in making their recommendations. Again, in 2014 and 15, looking at the benefits and harms. And this was not in the paper for reasons I'll mention. Model M estimated that the percent of overdiagnosis was about 24%. Due to screening, annual screening. And every other model was the 2 to 3 to 4% range. I'm an order of magnitude bigger than this. This was a a concern for the task force. They said, Barry, why are you the outlier here? And I said, no, why are these the outliers? No, I didn't. I tried to explain to them what the difference was. So I looked under the hood. We're going to look under the hood just a minute. Remember this? And remember that no screening and no adjuvant therapy. This is model M. So this is no screening incidence, just a slight increase. And this is mortality, nowhere near the increase that we saw in the other models. So why is that? The answer is that we consider uncertainty in model M. There's a parameter called the age period cohort model, the one on the right here. And this is flat incidence. This is that model, the APC model. And I started by assuming that I didn't know. I knew I didn't know, but I assumed a distribution for how much to count this APC, and I'll let the data tell me how much to count. Similarly, for other parameters, of which there are 8 or so, the tamoxifen effect. So this suggests that tamoxifen effect in the population is better than we saw in the clinical trials. This is, again, the prior distribution. This is after the models, using those 66 simulations. So under the hood, model M discounts the APC, makes no assumption that breast cancer death is inevitable if you live long enough. And the other models, or at least several of the other models, assume that. In sum, model M is Bayesian. It starts with great uncertainty. It factors in whatever the available evidence is, and it ends with somewhat less uncertainty. The question is still open, but with greater certainty, pointing back to what the New York Times said. That even though I built model M prospectively, cautionary note, modelers can always choose inputs to get the desired outputs. It's difficult, I'm saying I didn't do that. It's difficult to prospectively design a model building process while blinding to the inputs. Screening is controversial. Most modelers publish conclusions supporting their biases. That's an empirical fact. Despite laudable efforts such as CISNET, scientific standards in modeling are deficient. So I'm not going to talk about this. You can ask questions about this. This is the COVID-19. The patients, the people who are not being screened, much ado about that. They're delaying cancer screening, and therefore, according to some, we're afraid of the cancer pandemic that will result from this. 1 in 8 women will be diagnosed with breast cancer. We are missing so many cases when all 8 women miss their mammograms. And my question is that good or bad? Takeaway messages: models don't address the uncertainty, are nearly worthless. Uncertainty and credibility depend on these things. Overdiagnosis exists, but its rate is confounded with other factors, and so it's difficult to quantify by models or any other process. And now to change an oft-heard expression credited to Churchill and others: there are lies, damn lies in statistics. I say there are lies, damn lies in models. Believe the model to the extent that you respect the modeler. So I'm done. Thank you.
Thanks, Don. And Stephen, I think you've taken a look at some of the questions that have been proposed. You want to tell us what they were?
Sure. Well, one, I'm just curious. So Don But I thank you both to the speakers. Those were wonderful talks. Don, you ended with this advice. I mean, you've highlighted the importance of accounting for uncertainty and all the assumptions in the models and all that. And you ended with this advice to respect the model to the extent that you respect the modeler. And I'm just trying to operationalize that. What advice do you have for us? How do we figure out if we should respect the modeler?
Yes, that's a good question. I knew you were going to ask me that question, and I'm not going to give a terribly satisfactory answer because I don't think there is one. One thing to do is look at the history of the individual and what they've done. We researchers tend to become entrapped. So we make statements, we publish papers from a particular perspective. We fall in love with our own ideas. And so if you see that, you'll learn to discount, especially when they come up with answers that are consistent with what they've always been saying. Another related issue is if they happen to be, they've gotten grants or they're working with investigators. That was certainly true in the Consensus Development Conference in 1997 about the screening mammography for women in their 40s, that there were statisticians who were employed by and worked with radiologists who came to think in a particular way. So it's looking at what you can infer from their biases. It's sort of like a Supreme Court judge that's been nominated, that you look back to see what his or her statements were. And so that puts a premium on somebody who is uninitiated, but they still have biases. So it's not an easy question. I can tell you, Steve, when I read something in the journal Cancer, I immediately discount it because the journal Cancer has this history of publishing really some horrible modeling papers and papers about screening mammography. And so I take into consideration, everything that I can. I've already said too much and I've said nothing.
Okay. Then there's some questions for Jennifer. Jennifer, one question was, you focused on people who get screened above the age limit. What about people who are below the age limit? Did you look at that?
I did not look at that in this analysis. We were just focusing on people, ages 75 and up or 60, 66 and up.
Okay.
So yeah, you can be overscreened if you are screened too frequently, and we heard a little bit about that too. But the way the questions were formatted in the behavioral risk factor surveillance system survey, you wouldn't be able to see, you can only capture everyone's last screening test, not how often they were screened.
Okay. Then another question was about, does the overscreening continue to go up and up as people get older, or does it start to drop off? What happens to the people as they get really old?
Yeah, so we did several supplementary sensitivity analyses to look at the older groups, even within this older adults, and differences by a calculated life expectancy or predicted mortality over the next 10 years. And what we saw is that, there wasn't actually a big reduction in overscreening for people who were we looked at over 85. They still had pretty similar rates of overscreening to the people who were 65 to 85 or 75 to 85. And the same thing for calculated life expectancy. There was not a big reduction like you would expect to see, that the oldest old or people who are sicker, who have more comorbidities would have a reduction in overscreening. So I go into great detail about it in the paper, but the take-home message is that we didn't see the reduction that you would want to see, because these people aren't going to benefit as much from cancer screening.
Okay. There's a related question. Did you look at overscreening not because of being done at a specific time cutoff, but because life expectancy was too short? I guess you could expand that to other sort of risk-based approaches to screening.
Yeah, so we, as I said, we didn't have the health records for the participants in the survey. We had their self-reported comorbidities, and we were able to calculate their estimated life expectancy, and but we couldn't look at things like family history or family cancer history. Or we did have cancer history for the participant, but not if they were at higher risk for familial-based cancers. But again, we looked at it both continuously with this index of mortality risk and categorically a cutoff of 50% in terms of of estimated probability of death within the next 10 years. And again, we didn't see much reduction. For breast and cervical cancer, we did see that if your estimated mortality risk got very high, it was slightly lower probability of overscreening.
Okay. Then here's a question hot off the presses for Dr. Berry. The question is, ensemble models usually have better predictive ability than the individual components. Is there some way of combining the 7 models in some principled way, and is this evident in CISNET?
So I tried to do that. I mean, I think that's critical. I mean, one of the great manifestations of Rocky Foyer's genius is the many models, and to precisely do this, to understand what is the modeling variability, what is the model aspect as opposed to the data and the inputs, because all of these 7 models had the same inputs, at least in terms of data. The way they were handled, of course, is different, as I indicated. So yes, but what it means is greater variability. It's a greater uncertainty, and there's kind of like more precision, but more precision in terms of what we don't know. And that was the whole point of this thing I put in the New England Journal to show the variability of the various estimates. But there was some sort of commonality, and it was the commonality that was important, recognizing the uncertainty. So I agree with what you say, and we tried to do that.
Okay. So Barry Kramer, it's 5. Should we continue with more questions, or what?
Well, I think we can continue for 1 or 2 minutes, since we started a few minutes late, if that's okay with Ruth. I think she decided that an additional 5 minutes would be permissible within variability.
Okay. Okay. Another question for Dr. Barry. It's sort of related, but you said that standards, scientific standards are deficient for modeling. And I mean, I guess this is related to the first question, but how are we as I'm speaking for someone like me, a non-expert in modeling, what are there ways to figure out how to be a wise consumer of models?
Yes, I mentioned some before in answer to the previous question. Sorry, I was taken aback here. how do you tell? How do you believe a model? You can't, of course, as a consumer, dive into the, look under the hood and change the carburetor. But you can try to do this looking at meta-analysis sort of what separate from. Did I answer the question? Did I come close to answer the question? Where is the question on the chat?
It's an amalgamation and intuition.
Okay. So does it resonate? What are the data going into it? Sometimes, I mean, this issue about assuming that all cancers are deadly, it's just that they take a long time to kill, possibly. That's clearly wrong. And one of the questions on the chat talked about the immune system potentially getting rid of cancers during the Sojourn period, which there's been a number of studies that are addressing this difficult question. And so if you see that assumption, I would discount the model.
Okay. I guess it's time. We've gone over by a few minutes. And I want to thank everyone for participating. Stephen for monitoring the chat, Ruth for helping us arrange this, and Doctors Moss and Berry for outstanding presentations. So I am going to now flash up my very last slide, which is, let's see, is the announcement of the next series. I'm having a lot of trouble here. See if I can see. Share screen, PowerPoint. Well, the next session is going to be on the 17th of November at 1600 hours, but you have to keep in mind that that is Australia Eastern Standard Time. Please dial in for that. And the last thing I want to mention is that the Scientific Planning Committee is planning for a full Preventing Overdiagnosis meeting in person, complemented by continued Zoom sessions of the in-person meeting in the fall of 2021. And hopefully, if all goes well with the pandemic, it will be held in Calgary, Canada. So please stay tuned to register for that and to submit abstracts. And with that, I think we can close. Stephen, did you have any parting comments?
No, just thank you to everyone for participating. And I really want to thank the speakers for these wonderful presentations and your work.
Thank you so much for having me.